So I hope everyone is preparing well, and hardly we are having more than 20 days for our NEET. So today I will try to discuss and cover all the recent previous MCQs which has been asked in past 4 or 5 years. Okay. So we will start from END side, the questions that has been asked from END side. So this was one question which has been asked in NEET 2023, reason 1. A 3-year-old child with a fever and biphasic stridor, radiograph of neck is given. What is the diagnosis? So the options given are acute laryngotracheobronchitis, acute epiglottitis, laryngomalacia, and foreign body. So what's the answer here? A, B, C, or D? Yeah, everyone good. That is A. It is acute laryngotracheobronchitis. So actually, this is the steeple sign. This is the steeple sign. So in exam, whenever they are giving you an AP radiograph like this, see this is an AP radiograph, anterior posterior radiograph, and you are seeing some pointed steeple-like appearance. Steeple means the top portion of chest. Steeple-like appearance. Then you have to understand that you are dealing with. Acute laryngotracheobronchitis. Acute laryngotracheobronchitis. That is steeple sign. And in radiograph, they can also ask you about acute epiglottitis. In acute epiglottitis, what happens is they will give you a lateral radiograph. And in that lateral radiograph, you will be able to see a thumb-like impression in the region of airway. So in this is the air column. In air column, you are able to see a thumb-like impression. So easily, for making it correct confidently, if they are giving you lateral radiograph, it is most probably the thumb sign, and thumb sign is usually seen in acute epiglottitis. So another ENT related signs in radiology, another important ENT related signs in radiology, one is Hoffmann-Miller sign. Where you will get Hoffmann-Miller sign? Where will you get a Hoffmann-Miller sign? So Hoffmann-Miller sign will be seen in, excellent, it is seen in JNA. Very good, very good. It is seen in JNA. And the other questions that has been asked regarding JNA, what is the site of origin of JNA? Where is the site of origin of JNA? JNA originates from sphenopalatine foramen, which is seen in pterygopalatine fossa. So pterygopalatine fossa is a fossa which is seen posterior to the maxillary sinus. So JNA arises from the maxillary, from the sphenopalatine foramen, and pushes the posterior wall of maxilla anteriorly. That is what is called as Hoffmann-Miller sign. Another question that has been asked, usually the patient presents with epistasis, a 15 or 16-year-old male boy. And what will be the other important point is you have to embolize. The tumor because it is highly vascular. So you have to embolize the tumor before you operate the lesion. So these are the four points that has been asked from juvenile nasopharyngeal angiofibroma. Another important ENT topic. Another important questions that can be asked from ENT sides are: which is the best view for finding maxillary sinus? Which is the best view for finding frontal sinus? So X-ray view for maxillary sinus. The best X-ray view for maxillary sinus will be, what is the best X-ray view for maxillary sinus? Any idea? Yeah, excellent. It is M. So we can just rotate M into W. That is Waters view. So just remember, Waters view will be best for the maxillary sinus. And if you want to image the frontal sinus, and for frontal sinus, basically Caldwell view. Excellent. Caldwell view will be the best. So these are actually the some of the questions that has been asked from END side. Now, coming to little medicine side, a 50-year-old with history of smoking has pain in right arm. There is history of ptosis. CXR is given. Finding is there. What is the diagnosis? Please quickly comment A, B, C, or D. Excellent. Everyone knows that this is Pancoast tumor. So, you know, this is not superior vena cava obstruction. In X-ray, we will not be able to find out superior vena cava obstruction. So, that you have to do CECT. Any vascular pathology, you can see. This is not aspergillosis. So, we will discuss about aspergillosis. Yeah, this is actually Pancoast tumor, also known as superior sulcus tumor. So this is pancreas tumor. So what are the questions that has been asked about pancreas tumor is actually what is the investigation of choice for pancreas tumor? X-ray will be the first. X-ray is the first investigation. What will be the investigation of choice? Excellent. That is MRA. Because this pancreas tumor will infiltrate the brachial plexus. It will infiltrate the adjacent vessels as well as brachial plexus. So you want to find out the neuronal involvement. So for finding out brachial plexus involvement, we have to do an MRA brain. That is the concept. You have to do an MRA to find out the brachial plexus infiltration. The other important questions that can ask from this side is what is the syndrome associated with this superior sulcus tumor? You will see Horner syndrome. So Horner syndrome, that is why the patient is having toes. What are the components of Horner syndrome? There will be three things. Yeah, Horner. What are the components of Horner syndrome? Yeah, ptosis, meiosis, and anhidrosis. So these are the three components: ptosis, meiosis, and anhidrosis. And now coming to aspergillosis, what are the CT signs of aspergillosis? Any idea? CT signs of aspergillosis? Actually, there is a sign called as halo sign and air present sign. Yeah, excellent. Air present sign. So these are the two signs of aspergillosis. So these are the signs of aspergillosis. Now, what happens is the competition is very tight, because everyone knows everything. Time was there. Everyone is preparing hard. So there is very narrow margin for error. So the margin for error is very, very narrow. So what you have to do is you have to make sure that you are regularly going through your workbooks. You are seeing the VSV notes of all 19 subjects. You are covering all the important topics, not entire topics. You are making sure that you are covering all the important topics so that the margin for error is very low, so that you will get a very good rank in exam. This is another previous NEET 2023 question which has been asked regarding END side. So actually in the history, they gave an history of non-axial proptosis of right eye, and she had a history of trauma 10 years back. Now, and also in history, they showed that there is a lesion in right frontal sinus. They mentioned that there is a lesion in right frontal sinus. So what is the diagnosis here? That was the question. Actually, I will tell you the anatomy. This is the eyeball, this is the orbit, and this is the eye. This is the frontal sinus in left side. This is the right side. This is the right frontal sinus. This is maxillary sinus. This is maxillary sinus. This is the inferior turbinate. Because they may ask you anatomy. Anatomy of PNS is very easy. So I will just tell you, this is the inferior turbinate. So this is the anatomy. So what is the diagnosis here? Is it A, B, C, or D? Is it frontal mucosal? Is it frontal meningioma? Or is it orbital pseudotumor? Or is it JNA? Actually, the question itself is very easy. They are telling you there is a lesion in right frontal sinus. So which among these is a lesion from frontal sinus? So we discussed already, JNA is not a lesion of frontal sinus. It arises from sphenopalatine foramen of pterygopalatine fossa. So this is not the answer. Orbital pseudotumor is not a lesion of frontal sinus. It is a lesion of orbit. So you can easily rule out that option. Meningioma arises from where? What is the organ of origin of meningioma? Meningioma arises from where? Any idea? Meningioma arises from? So meningioma arises from dura. Actually, it is a lesion of brain. Okay, so it is seen inside the brain. It arises from dura. So it arises from the dura. So it is not meningioma. So only one thing that is remaining is frontal mucosal. This is how a mucosal appears. Okay, mucosal is seen just like fluid. So it is actually frontal mucosal. So you have to rule out the answers. Okay. So meningioma is one of the most common tumors which is seen in old age. It can have ERPR status. What is the common type of histopathological appearance of meningioma? What is the common histopathological question that asked from meningioma? That is regarding what bodies? Some of my bodies will be seen. In MRI or CT, there will be dural tail sign, mother-in-law sign. So some of the concepts, some of the questions that has been asked will be this. So some of my bodies, dural tail sign regarding meningioma. So this is all about meningioma. So this was frontal mucosal. So when you don't know the answers for this type of questions, what you have to do is you have to use your common sense and rule out. JNA is not arising from frontal sinus. Orbital pseudotumor, the name itself says it is from orbit. So it is not a orbital pseudotumor. Meningioma is usually seen within the brain, not in sinuses. So it is probably frontal mucosis. So only by ruling out 4 options, you can reduce the mistakes that you make out. Okay, so make sure whenever you are attending, you are ruling out all the 4 options. You should rule out all the 4 options. I'm going little fast because this is a revision session and I have to cover a lot of topic within 1 hour. Okay, so I am trying to cover almost all the repeat questions in 1 hour. This is another repeat question, not NEET, but they can ask this question in NEET or INSET in whichever exam you are attending. That is that much important. So this is a young patient who he was brought to the casualty following RTA. So his BP was 180/60, respiratory rate was 40, and X-ray is given. So what is the diagnosis here? Please everyone try to comment the diagnosis here. This is the right side, this is the left side. So which side is pathological in this radiograph? Excellent, excellent. You have to know, because without knowing this, you should never go to exams. Because if you see this is the right side, you can see the bronchovascular markings here. You are able to see the bronchovascular markings here. So this is right pneumothorax. Excellent. Everyone knows this. This is right pneumothorax. So what was the pneumo question that asked in INICT? Was it pneumothorax, pneumopericardium, pneumomediastinum, or pneumo? What was the question? Just pneumocephalus. What sign they asked in our Mount Fuji sign? Excellent. So that was Mount Fuji sign. That was seen in our brain. That is in tension pneumocephalus. Mount Fuji sign. So now they can ask you pneumothorax. See, here you are not able to see any vascular markings. Here you are able to see deep sulcus. Deep sulcus, absent vascular markings. So this is pneumothorax, and see what happens is, this is here the patient is having reduction in BP and pulse rate, reduced pulse rate and BP. So this is tension pneumothorax. So you have to do emergency chest tube insertion. Okay, you don't have to confirm with CT because this is very evident. So no need for CT. Pericardiocentesis will be done for which condition? Pericardial tamponade or pericardial effusion. Emergency thoracotomy is not need. There is no need for emergency thoracotomy here. So what you have to do is you have to put a chest tube. So where will you put chest tube? That will be the other question. Where you have to put the chest tube? At which intercostal space? 1, 2, 3, or 5? Which intercostal space you will put in emergency thoracotomy? Yeah, we have to put it in triangle of safety. Okay, so these are the questions. Now, what is the ultrasound sign, USD sign in pneumothorax? So what is the ultrasound sign in pneumothorax? Can anyone comment? Normal length, how it will be seen? So, yeah. USD will be barcode bar stratosphere in ultrasound. Normal length will be seen as seashore. I always tell seashore is a good place. Seashore means that is normal, but barcode is not that good. Okay, normal seashore. So these are the repeat questions that have been asked regarding pneumothorax. I hope everything is clear. So we will move forward. Now, in this question, actually this question was asked in NEET as well as in INICT. So in this question, they gave a very big clue. They gave a big clue of sterile pyuria. So whenever there is sterile pyuria, you should think about only one thing. That should be excellent. That is renal TB. You should think about renal TB. So in renal TB, the final stage of renal TB is putty kidney. So the final stage of renal tuberculosis is putty kidney. So what happens in putty kidney is there will be complete calcification. There will be complete calcification involving both medulla and the cortex of kidney. Involving both medulla and the cortex of the kidney. So this is what happens. So the entire kidney became cement-like. That is what is called as putty kidney. So you should know how to differentiate between a stack-on calculus, putty kidney, and a psoas calcification. Actually, this is the psoas muscle. So if you are seeing calcification here, then it is psoas calcification. So this is not psoas calcification. So imagine this is the right kidney. If you are seeing a calculus in the pelvis region like this, then it is stack-on calculus. So it will be seen in the pelvic portion of the kidney, and nephrocalcinosis will be usually bilateral. I will show you the images. See, if there is complete calcification, this is putty kidney. Here, if you see carefully, this will be the cortex. The cortex is not calcified. Only the pelvis portion is calcified like this. So if only pelvis is calcified, that is staghorn calculate. Don't confuse in exams. And if you're seeing bilateral calcification, whenever there is bilateral involvement, that is usually some endocrine pathologies like hyperparathyroidism, hypothyroidism like pathologies. That is why systemic causes will causes bilateral involvement. Since it is a systemic cause, there is bilateral involvement. Okay, so it will be medullary nephrocalcinosis. So medullary nephrocalcinosis will be usually bilateral because it is associated with hyperparathyroidism or hypoparathyroidism like conditions. Okay, I hope this is clear. So this is how you differentiate. So in this exam, this was the most catching point. If you are seeing the history of sterile pyuria, if you see sterile pyuria, then you can be confident that this is renal tuberculosis. Now coming to this question. So here a patient is coming with acute onset of chest pain. His chest image is provided. What is the diagnosis? This is another NEET-PG 2018 question. A direct question which is simple, very, very important. Okay. So what is the diagnosis here? Is it A, B, C, or D? Please comment. Yeah, aortic dissection. Now my question comes. This is the lens fields. So what is this anatomical structure? A. What is the anatomical structure? A. Because I know everyone will make this question correct, but I want to improve your knowledge. What is A? What is B? You have to tell me what is A and excellent, excellent. A is SVC, very good. A is SVC, excellent. So, and what is B? Which portion of aorta? Is it the ascending aorta, descending aorta, or arch of aorta? Very good, excellent. This is arch of aorta. B is arch of aorta. So, this is an arch of aorta dissection. So, my question comes. How will you classify this? How will you classify this aneurysm according to DeBakey and according to Stanford? Coming to surgery pathology, how will you classify this aneurysm? Is it Stanford A or Stanford B? Is it DeBakey A, B, or C? Yeah, excellent. This is Stanford A. DeBakey you cannot see with one image. It can be either DeBakey A bar B because one or two. Consider it as one. So when it is Stanford A, what will be the management? How will you manage this patient? These are the three questions that has been asked from aortic dissection. How will you manage the patient? When you are getting a Stanford A patient, how will you manage the patient? Yeah, first you have to control the BP and surgery. Surgery will be the definite management. But if it, imagine it is a descending thoracic aorta aneurysm and you are classifying it as Stanford B, how will be the management? Management will be medical. You have to give esmolol or hypertensive management again. So if it is Stanford A, then the treatment is surgery. If it is Stanford B, that is aneurysms involving descending thoracic aorta, you can conservatively manage the patient by giving antihypertensives like esmolol. So these are the questions that has been asked from CT angiogram. So now other questions that can ask from CT. So what is the contrast agent that we give in CT? What is the contrast agent that we give in CT? We have to give iodinated contrast like iohexol. So this is an iodinated contrast. This is a contrast image. So if they ask you, if you're suspecting aortic dissection, what is the investigation of choice? What is the investigation of choice for aortic dissection? What should be your answer? What is the investigation of choice for aortic dissection? Yeah, we have to do a CT angio. This is a CT angio image showing aortic dissection. So what is the HU value of contrast? In last INA-CT, they asked the HU value of CSF. So what is the HU value of contrast? When you give contrast, how much HU value will increase? What is the HU value of contrast? It is actually 30 to 40. What is the HU value of air? They can ask you all sorts of questions like this. What is the Hounsfield unit or value of air? Excellent. Is it plus 1000 or minus 1000? That is the catch. Okay. HU value of air is usually minus 1000. What is the HU value of bone? Bone will be plus 1000. Okay. So this is how you should remember things. HU value of bone will be plus 1000. HU value of air fat will be negative. Fat will be minus 100, air will be minus 1000 in that range. Okay, bleed will be 50 to 60, calcification will be 100 to 200. So those tables regarding fundamentals of CT is very, very, very important. Okay, so if it is calcification, it will be 100 to 200. If it is fat, minus 100 to minus 200. Things will go like this. Okay, this minus 100 to minus 200. So all these are the concepts that are very, very important regarding CT. I hope this is clear. Yeah. Now coming to the effects of radiation, that is another very important. In our radiotherapy chapter, there is one table which is of very, very importance. So you have to read. So this is a 3-year-old child of ALL going for complete irradiation, cranospinal irradiation for ALL. So which of the following cells in the patient is least affected by radiation? Is it A, B, C, or D? Actually D. So why D? According to the law of Bourguignon and Tribondeau. What these law says? Yeah. Undifferentiated cells are more prone for radiation damage. Neurons are differentiated cells that are less rapidly dividing or non-dividing. Since it is a non-dividing cell, less radiation damage. So it is a non-dividing cell, so there is less radiation damage. So if they ask you which of the following cells is most, if they change it to the least into most, if they change the least into most, what will be the answer? Please tell me. A, B, C, or D. Yeah, then it will be usually bone marrow cells will be the first to affect. Okay. Now come to the other question. Again, radiotherapy, and this question is very, very important. Last NEET-PG 2023 question. 45-year-old underwent radiotherapy for CS cervix. Find out the true statement regarding ionizing radiation. Find out the true statement regarding ionizing. First is, normal cells and cancer cells are equally sensitive. The effect of radiation is inversely proportional to the square of the distance from the source. GA mucosa is most resistant to the tissues. Small blood cells are resistant to the effect of radiation. What is the answer? Excellent. Everyone know. So tell me what is B? Why that is the answer? What is B? It is called as inverse square. No. So if you increase the distance, the radiation dose will decrease by the square of the distance. If you increase it 2 times, the radiation dose will decrease by 4 times. That is what is called as inverse square law. So if you double the distance, the radiation dose will decrease 4 times because the square of 2 is 4. So that is what inverse square law. So you know, cancer cells are rapidly dividing cells. So they are more radiosensitive. GA mucosa is very sensitive because GA epithelium is also rapidly dividing epithelium. Whether the blood vessel is small or large, it will be radiosensitive. It is radiosensitive. So some important points that you have to understand is, well-differentiated quiescent cells like neurons are radioresistant, rapidly dividing cells are radiosensitive, and 2 important effects that I have to revise here is about the deterministic effect and stochastic effect. The questions that ask is, cancer that occurs as a result of radiation exposure is deterministic or stochastic? You have to tell me. Cancer that produce after radiotherapy, like papillary carcinoma of thyroid, meningioma, osteosarcoma, can be associated after radiotherapy. So these cancers is seen after radiotherapy is stochastic or deterministic. Excellent. This is stochastic. So stochastic cancer. How you can remember in exam is C for C. Stochastic is C in C. There is stochastic, and C is there in cancer. So C is common in both. So cancer which occurs as a result of radiotherapy is stochastic effect. So some examples of deterministic effect. Deterministic effect means D for D. It is dose dependent. So this is dose dependent, and it is independent. So here what happens is, after a threshold dose, the effects increases. So if I increase the dose of radiation, the side effects will be increased. So the side effects will be increased if I increase the dose of radiation. So examples are skin erythema, hair loss, bladder injury, bowel injury, like this. Coming to stochastic effect, I told you it is dose independent. So dose independent means if you increase the dose, the severity will not increase. The probability will increase. If you get more radiation, you will be having more probability to get cancer. That will not mean you will have more severe cancer. Okay. So it is an all or none phenomenon. It is an all or none phenomenon. Okay. It is an all or none phenomenon. Some of you may develop cancer after getting radiotherapy. Some of the patients may not. Okay. That is the concept of stochastic effect. So these are the questions that have been asked. Then there is a very important table in our workbook regarding which cells are which cycle, which phase of cell cycle is more sensitive, which is least sensitive, which cells are more sensitive, which tissue is more sensitive. You have to revise that table before you go to the exams. Then another important thing is simple question, that is CVS. We will cover cardiovascular. The vascular part of aortic dissection is over. Now cardiac part. Radiograph of a newborn with the cyanosis. What is the diagnosis? Please tell me whether it is A, B, C, or D. Yeah. So this is snowman, which is seen in supracardiac type of TAPVC. And now we will quickly revise the heart shapes. So tell me what is A, what is B, what is C, and what is D. If you tell me all the four, that's all. Cardiovascular system in radiology, the most important topics are covered. Yeah, excellent. A is egg on side, which is seen in transposition of great arteries, that is TGA. The question that can come is whether there will be pulmonary plethora or oligemia. This is associated with the plethora. So these are the three questions that has been asked from TGA. B is TOF. In TOF, there is pulmonary stenosis, so less blood. So this is less blood. So this is pulmonary oligemia. There is pulmonary oligemia. What is C? Excellent. C is a box-shaped heart. Don't confuse it with pericardial effusion. Pericardial effusion, usually they don't give you children X-ray. They will show you an adult X-ray, just like in our INACT. History will be there. There will be history of Beck's triad. What are the components of Beck's triad? In that, the question was actually directly straightforward. There was history of some viral fever and chest pain. And what are the components of Beck's triad? They didn't ask you components of Beck's triad. They told you to find it out from the options. So there will be muffling of the heart sounds. In the option, they got showed loudest one. So there will be muffling, means since there is fluid, you will not be able to hear the heart sounds well. So in pericardial effusion, there will be muffling. But here, it is not pericardial effusion or that leather bag appearance. It is a child with a box-shaped heart. This is box-shaped heart, which is seen in Epstein's anomaly. And Epstein's anomaly, the question usually comes is the association with the lithium. If there is maternal uptake of lithium, lithium is usually given for mania or other psychiatric disorders. So if there is maternal association of uptake of lithium, these patients can develop. Yeah, excellent. So in Beck's triad, there will be elevated JVP, decrease in BP, and irregular respiratory rhythm. Okay, so these are the components. Okay, so lithium, Epstein's anomaly, box-shaped heart. And anyone about D? Everyone knows ABC. What is D? If I draw an eye like this, can you tell me what is D? Any duct you know? Excellent. Excellent. Okay. This is sitting duct. Sitting duct. Sitting duct is seen in persistent truncus arteriosus. So it is a duct, sitting duct, which is seen in persistent truncus arteriosus. So these are the points that you should remember when you are revising cardiovascular system. Now, there is no margin for error for this type of straightforward question. Identify the location of foreign body. Questions are straight. Excellent. Everyone knows. So if it is an in-phase view round like this, then you can remember esophagus. Esophagus also has an O. This also has an O. So this is esophagus. In-phase view. If it is in trachea, it will be usually slit-like appearance because of tracheal cartilage. It will be slit-like because of tracheal cartilage. Trachea has cartilages. So what happens is foreign body can orient only like this. So you will be seeing it like slit. So everyone knows this. Then the INACT people came with another question. So this is the slit-like view because of cartilages. Okay. So this is how it is seen in trachea. This is how it is seen in esophagus. You should never make it wrong. And they asked you identify the type of foreign body in INACT, last INACT, not this one. This before. They ask you to find out what is the foreign body. Identify the type of foreign body. So is it A, B, C, or D? Is it a metallic bowl? Bowl should look like a bowl. So this is not a metallic bowl. Cap of cold drinks, you know, in Coca-Cola bottles, there will be some irregularities. No irregularities seen. So no, not a cap of bottle. So is it a coin or button battery? How will you differentiate? Yeah, it is a button battery because if you assume it clearly, there is one halo surrounded by another halo. So if whatever name you can use, double ring or double halo, whatever you can use. Okay, but the double ring or double halo is usually seen in button battery. And remember, button battery can release alkalis resulting in perforation of esophagus. So only the important things will be asked in exam. So if they ask you to find out, make sure it is not a button battery before you choose any other option. Okay, if you are seeing this halo like this, then it is double halo sign. That means it is a button battery. Coin is usually homogeneous. So these are the concepts that you should remember when you deal about foreign bodies. Now, this is another AIMS 2017 question. A 72-year-old lady with a history of behavior abnormalities was born with OPD with recurrent abdomen pain, behavior abnormalities, so bone pain. So there is bone pain, groin pain, and moins. And provisional diagnosis was made. So it is hyperparathyroidism. So what is the best for making out parathyroid adenoma? Hyperparathyroidism is usually caused by parathyroid adenoma. So if you want to find out parathyroid adenoma, the best modality will be systemic scan. The systemic scan. So what are the findings? What are the musculoskeletal MSK findings in hyperparathyroidism? In hyperparathyroidism, what happens is there will be increased serum calcium. You know, calcium levels will be increased. That is why you are having abdominal pain because of renal calculi. So the calcium levels will be increased. There will be medullary nephrocalcinosis like picture. What happens is, how calcium is increased? Because it is because of increase in bone resorption. They will take calcium from all the bones. So there is increased bone resorption. So what happens is there will be resorption in phalanx, the radial aspect of second and third phalanx. You know, it is given in a workbook. What type of skull? What type of skull you will see in hyperparathyroidism? What type of skull you will see in hyperparathyroidism? Any idea? Different types of skull? Excellent. Excellent. You will see salt and pepper. You will see salt and pepper type of skull. Okay. So these are the questions. What tumors? What tumors which is common in hands or shoulder or wrist? What tumor? What is the name of the tumor that is seen in hyperparathyroidism? Any idea? Actually, it is not a tumor. It is a misnomer. But any idea? Have you heard about Brown's tumor? Excellent, excellent, excellent. So Brown's tumor, excellent. So these are the points that you have to revise before you go, because hyperparathyroidism can have variety of manifestations. Musculoskeletal that is MSK, orthopedics management is very, very common. So there will be resorption along second and third phalanx, subclavicular resorption can be seen. All these images are there in our workbook. Okay, please quickly revise after this session. Just take 2 or 3 minutes and revise these things after this section. So this is a CT image showing parathyroid adenoma, but MRA, it will, sorry, this nuclear medicine system B will show it very clearly. So everyone know about system B, and INSCT people asked which is better, whether it is technician 99mm system B or system B SPECT. SPECT has CT. When there is CT, it is superior. Okay, because system B, what happens in nuclear, it is a 2-dimensional like this. You will see just like an X-ray. But if you are seeing an image like this, with the PET or uptake, so it will be better. So this is a 3-dimensional, so it is better. SPECT is better. So in last INSCT, the answer was SPECT. Okay, when there is system associated with SPECT, that will be better. So that is another concept. See, this is a SPECT image, but this is our technician 99 system. So please tell me which is better. This is system SPECT. So you know. Anyway, this will be better. So this will be the answer. So this is SPECT. Okay. So that is the concept. Now, one more question which I let out from END. A patient with a chronic ear pain, discharge, severe headache came to you, and you took an image, CT brain with the contrast, and you are seeing a lesion, ring enhancing lesion. Actually, if I take, what is the diagnosis? Is it an extradural abscess? Is it a subdural abscess? Is it a cerebellar abscess? So if it is an extradural abscess, just like extradural hemorrhage, it should look like Italy or biconvex. It should look like biconvex or it look like an Italy. So it is not extradural hemorrhage. If it is subdural hemorrhage, it should be concave or convex like this. Okay. In subdural abscess. Cerebellar abscess should be in cerebellum. This is cerebellum. So this is a temporal abscess. And you know, temporal abscesses are complications of automastoiditis. When there is automastoiditis, these patients are prone for developing temporal abscess. So that is the concept. Yeah, this is another question which was asked in INACT last year. So, a patient presented with or URPA orbital pain, what is the most likely diagnosis? Is it a sinusitis with a subperiosteal abscess, orbital abscess, preseptal abscess, or sinusitis? Actually, this is a question. Actually, it is a difficult question. See, I will tell you the anatomy. This is the temporal lobes of the brain. When you are seeing the eyes, the section that you see will be the temporal lobe of the brain. This is the eyeball in right side. This is the ethmoid sinus. So if you see ethmoid sinus in right side, it appears normal and air-filled. Air-filled means it will be black in color. It is normal and air-filled. But what happens in left side is there is sinusitis. So this is a patient with a complicated sinusitis. And if you see, this is the bone. This is the lamina papyracea or lateral wall of ethmoid sinus. And if you're seeing there is a collection adjacent to the bone. So whenever there is a collection adjacent to the bone, that is subperiosteal collection. That is subperiosteal collection. Okay. Whenever there is a collection noted adjacent to the bone, that is subperiosteal collection. So this is how the concept goes. So this is the collection. Okay. So this is subperiosteal collection. So actually there is one classification called as Chandler classification, in which class 1 is the preseptal cellulitis, that is seen anterior in the preseptal part, in the eyelid part, and some in type 2, that is orbit part. The entire intra-orbit content or intraocular contents are involved. In type 3, there will be subperiosteal collection just adjacent to the periosteum of the bone. Since the collection was noted adjacent to the bone, it is subperiosteal. If they are, so you don't need to study entirely about this, but once it was asked, okay, so just for your knowledge, if it is in adjacent to that, then it is. If you are seeing it inside the I like this, then it is not superior, it is intraorbital abscess. Okay, that is the concept. Any of these abscess can result in cavernous sinus thrombosis. So these are the concept. Any of these abscess will result in cavernous sinus thrombosis. Now, another very important question. A 30-year-old male with a gradual swelling around the wrist, X-ray is given. What is the diagnosis? Is it Ewing sarcoma, osteodyostoma, giant cell tumor, or chondroblastoma? Yeah, excellent. Everyone knows this is. So I will tell from the points. First point is mature skeleton. That is more than 20 years. First point. ECT occurs in mature skeleton. First point. Second, it is an epiphyseal lesion. Third point, soap bubble appearance. And fourth point, subarticular destruction. Third point is subarticular destruction. So these are the 4 points that you should remember about the giant cell tumor. So if you are seeing a tumor after 20 or 30 years with a soap bubble-like appearance involving the epiphyseal region, destroying the subarticular region, then it is nothing else, that is giant cell tumor. So one doubt that you can come is between giant cell tumor and ABC, aneurysmal bone cyst. But you should never make that wrong, because aneurysmal bone cyst is seen in skeletally immature patient. The epiphyseal region is normal. Usually it is a lesion of metaphysis. See, it is a lesion of metaphysis. And if you aspirate here, you will see osteoclast or giant cells. But here you will see only blood, and MRI can show fluid level. Okay, that is not that important, but it is a lesion of epiphyseal region. It is seen in a skeletally immature patient. These are the 2 important points that will help you to differentiate between GCT and ABC. I hope that is clear. Now coming to Ewing sarcoma. What happens in Ewing sarcoma? It is a tumor of which decade? First and second decade. Classically, what you will see is, you will see onion peel periosteal reaction, and it is actually a tumor of diaphysis. Sorry, it's actually a tumor of diaphysis. Actually, this is an orthopedic revision too, so pay more attention. Combination of radiology orthopedics is notorious. What is osteodyostoma? What will be the classical age group? It is actually seen in first to second again, but within 20 or 30 years you will see osteodyostoma. Classical history will be night pain relieved by salicylates. So the classical history will be night pain relieved by salicylates. So what happens is, it's usually seen in the cortical region of the bone. There is a small lesion like this that is called as the nidus. So you will be able to see a nidus, and this nidus will release the prostaglandins. This nidus will release the prostaglandins. This prostaglandins is causing the night pain. So if you give any prostaglandin inhibitor like aspirin or salicylates, there will be the relief of the pain. That is what happens in osteodyostoma. So once they ask what is the treatment of osteodyostoma, anyone knows the treatment of osteodyostoma? Is it surgery, surgical excision, or anything else? Yeah, it is CT guided radiofrequency ablation. It is CT guided radiofrequency ablation. So these are the questions that has been asked about osteodyostoma. GCT we already discussed. Chondroblastoma is another important tumor which is seen in first decade. It is an addition of epiphysis again, and it is also called as Codman tumor. It's called as Codman tumor. And finally, if you do HP, you will get one specific type of calcification called as chicken wire calcification. Chicken wire calcification. So these are the questions that has been asked regarding chondroblastoma. So, okay. Anyway, please revise the bone tumors because it is a mixture of radiology, orthopedics, and pathology. So very, very important. Okay. So now coming to the another question. A 24-year-old young male. Again, age is very important whenever they are dealing with musculoskeletal system. A patient is having chronic back pain, then redness of eyes is there, morning stiffness is there, and every year in exam this question repeats. In 2019, 20, 21, 22, and 23, this question came. What is the answer for this patient? Yeah, that is, you should be very, very clear. This is a case of ankylosing spondylitis. If you see the sacroiliac joint, there is bilateral sacroiliitis. So if they ask you what is the best investigation to pick up ankylosing spondylitis at the earliest, then your answer should not be X-ray, it should be MRI. So can you tell me which sequence? Yeah, excellent. The sequence is still excellent. You know these things. So still MRI help you to pick out bone marrow edema. So bone marrow edema will be the first manifestation of any inflammatory disease like ankylosing spondylitis. So this is. So here you can see one sign called as the bamboo sign. This is the bamboo spine because there is endophytes going like this, giving like a bamboo like steady appearance. And if there is calcification of this interspinous ligament, you will get a sign called as dagger sign. So some signs you have to remember: dagger sign, bamboo spine, trolley track sign. So these are some of the signs that are very important in ankylosing spondylitis. These patients can have uveitis. That is why they are having redness of the eyes. These patients can have lung fibrosis. So breathlessness can be there. In last year, they gave the history of breathlessness. Okay. And sometimes there can be bilateral heel pains because of enthesitis. Heel pains is because of enthesitis. This is another case of ankylosing spondylitis. If you see, you can see there is ossification of anterior longitudinal ligament. Okay, usually they will give an X-ray showing bilateral sacroiliitis because that is the most pathognomic, and you have to do HLA-B27 to find out ankylosing spondylitis. You have to do HLA-B27 to find out ankylosing spondylitis. This is a seronegative arthropathy. So enthesitis causes heel pain. So sacroiliitis, this is the dagger sign. This is the bamboo spine. And if there's a fracture in the bamboo spine, that fracture is called as carrot stick fracture. So this is the entire spectrum of ankylosing spondylitis. This is the entire spectrum of ankylosing spondylitis. Please remember these images. Now, here the patient is having chronic low backache, hyperpigmentation, eyes, nose, Schober test is positive. What is the diagnosis? Is it A, B, C, or D? Excellent. This is ochronosis. Now, another question from biochemistry. What is the enzyme that is deficient in ochronosis or alkaptonuria? Since this is alkaptonuria, there is blackening of urine, eyes, nose, whatever structure, cartilages will be blackened. So what is, excellent. That is homogentisase oxidase. This is homogentisase oxidase deficiency. So this is a question. Why it is fluorosis? There is intervertebral disc calcification. There is intervertebral disc. Usually, we will not be able to see the disc. If you take your LS spine, lumbosacral spine radiograph, you will not be able to see these calcifications because this disc will not get seen calcified. So, but what happens in ochronosis? There will be intervertebral disc calcification. Now we will discuss about fluorosis. What is the classical finding in fluorosis? What is the classical finding in fluorosis? Radiographic finding in fluorosis. Yes, excellent. That is interosseous membrane. Interosseous. That is the membrane between two bones. There is interosseous membrane calcification. See, this is the radius. This is the ulna. And if I show you, there's a calcification between radius and ulna. This is what is called as interosseous membrane calcification. So please revise these things because these are important. Interosseous membrane calcification is usually seen in fluorosis. If they are showing meniscal calcification, imagine they are showing meniscal calcification in knee joint. Usually the meniscus will not be calcified, but if they are showing an X-ray of meniscal calcification, what will be the diagnosis? Where you will see meniscal calcification? Any idea? Have you seen our workbook again? What is pseudogout? It is also called a CPPD, calcium pyrophosphate. Excellent. That is pseudogout. That is calcium pyrophosphate deposition disease. So meniscal calcification is a feature of pseudogout, that is calcium pyrophosphate deposition disease. Okay, these are the calcifications that has been asked. Yeah, actually, if you see an image like this, you should not waste 1 minute in musculoskeletal system. What is the diagnosis? Whether it is A, B, C, or D. You are seeing ring-like epiphysis, ring epiphysis, white line of frontal. Just 2 points is enough. Metafacial flaring. So this is scurvy. Yeah, everyone knows this is scurvy. So sometimes they can show you a radiograph like this. If they are showing a radiograph like this, where there is cupping, see there is a cupping, then there is fraying and widening called as splaying. So when you are hearing cupping, fraying and splaying, what will be the answer? Cupping, fraying and splaying, what will be the answer? Excellent. This is rickets. So you should know how to differentiate between vitamin C deficiency, scurvy, and vitamin D deficiency. That is rickets. Both are very, very important. Yeah. Again, last INACT question. You should know the anatomy. If you know the anatomy, please answer A, B, C, or D, 1, 2, 3, or 4. So this is the patella. This is the femur. This is the tibia. You are seeing a ligament that is so this is patella. This is the anterior part. This is the posterior part. You are seeing a ligament that is attached to the posterior portion of tibia. So if you are seeing a ligament that is attached to the posterior part of tibia, no, it is not ACL. How ACL is a ligament that is attached to the anterior portion of tibia. The name anterior cruciate ligament means it is attached to the anterior portion of tibia. Here this is the patella, so this is the posterior portion. So don't make this mistake in exam. It is not ACL, it is PCL. Okay, so I will tell you again why. So some of you are making it mistake. See, this is the patella. That is, you are no there is no doubt this is patella, right? So if it is patella, this is the anterior portion. So this is the posterior portion. So this is the anterior portion. This is the posterior portion. So you are seeing a ligament that is attached to the posterior part of tibia. So ligaments that are attached to the posterior part of tibia is called as posterior cruciate ligament. Imagine they are showing you a ligament that is attached to the anterior portion of tibia. This is the anterior part. So that will be ACL. ACL will be attached to the anterior portion of tibia. That is why it is called as anterior cruciate ligament. PCL is attached to the posterior portion of tibia. That is why it is called as posterior cruciate ligament. Okay, don't confuse in exam. Simple anatomy. Please, I want every one of you to get a very good rank and get your desired seat. Okay, so work hard. That is the basic principle. Believe in yourself and work hard. See, this is ACL. This is a ligament that is attached to the anterior portion of tibia, not the posterior portion. So this is ACL. ACL is usually oriented like this. PCL is usually having a buckling like this. See, usually PCL will be having buckling appearance like this. ACL will be usually slant like this. Okay, and here this is one meniscus. This is another meniscus. This is how meniscus is seen in MRI. Everything will be T1, T2 hypo in normally. It will be black in both, hypo in both T1 and T2. These ligaments, meniscus, everything. If it is white, that means it is some fracture, there is some injury like this. This is actually an injured ACL, sprain of ACL. I'm not going into the depth. 18-year-old female, again, one NEET-PG question. Patient is having webbed neck, shielded chest. Which of the following imaging findings is most likely present in this female? Whether it is mitral valve collapse, subluxation of the lungs, cardiomegaly, streak ovaries. Yeah, it is streak ovaries because this is a case of Weber syndrome. Sorry, it is a case of Klinefelter syndrome, right? No, Turner syndrome. Yeah, Turner syndrome. Turner syndrome. 30-year-old female using OCP for last 1 year came with amenorrhea since 6 weeks. Which of the following is the best to calculate gestational sac age for? Is it abdominal gut? Will you check abdominal gut? Or will you do CRL by ultrasound? Or will you do calculation from 280 days or 250 days? Yeah, it is always CRL from ultrasound. Now coming to obstetric ultrasound, you will do the first scan that you do is the dating scan. Okay, because OG is very important. Okay, anyway, we will finish it in 10 minutes. Okay, don't worry. So the first scan that we do is the dating scan. Because I know your time is very, very precious. So I'm not willing to waste it. So first what happens is, imagine this is the endometrial cavity. By 4 weeks, you will see a sac like this. And this sac is called as the G sac, that is gestational sac. What happens by 5.5 weeks, 5.5 weeks is, inside the gestational sac, one more structure will come. That is the yolk sac. By 5.5 weeks, you will be able to see yolk sac. And by 6 weeks, what happens is gestational sac, yolk sac, and gestational sac, inside that yolk sac, and adjacent to the yolk sac, there will be an embryo. Embryo is seen by the 6 weeks. And by 7 weeks, heartbeat will come, FH will come. You will be able to see the heartbeat by 7 weeks. And when you do an imaging by 7 weeks, you will see double bleb sign. You will see a yolk sac, an embryo, and embryo is covered by another sac, which is called as amnion. So this is called as double bleb sign. Okay. So this is the double bleb sign. Okay, just so for finding out all these things, we have to do a dating scan. And by 11 weeks, we will be doing NT scan. By 11 weeks, you will be doing NT scan to find out nasal bone and nuchal translucency. Both of them are aneuploidy markers. So there is, if there is any increase in nuchal translucency, that is NT more than 3 mm, or if there is absence of nasal bone ossification, then you should suspect aneuploidy, and you have to check double markers, beta HCG and PAPA. That is again OG portions. Okay, beta HCG and PAPA. Okay, please revise all these concepts. So this CRL will be the the crown drum length, that is the distance between head and buttocks. So this distance between the head and buttocks will be the most accurate for finding out gestational age in first trimester. BPD, that is biparietal diameter, will be the best in second trimester and third trimester. In third trimester, if you want, you can also look for FL, that is femoral length. So identify the investigation. So no one should make this wrong. It's a very straightforward question. Is it histosalpingography, saline sonosalpingography, hysteroscopy, or laparoscopy? Yeah, this is not saline, this is HSG. You are seeing iodinated contrast, X-rays, bones. So this is X-rays. So you are injecting iodinated contrast and taking X-rays, and you are getting images of endometrial cavity, fallopian tube, and spillage. So this is an investigation that is usually done for finding out infertility. When you want to image the endometrial cavity and patency of fallopian tubes, for patency of fallopian tubes, you will be doing histosalpingography. Saline sonosalpingography is done under ultrasound. Okay, you are injecting saline, and images will not be like this. Images will be sono. Images will be sonographic images. Okay, so you should not confuse between A and B. So this is HSG. The questions that can come from HSG is how to differentiate between uterine didelphus, bicoordinate uterus, as well as septate uterus. So if you are seeing two cornua, 2 cervix, or sometimes 2 vagina, then it is didelphus. Everything is 2. So it is didelphus. It is uterine didelphus. But if you are seeing only 1 cervix, it can be either bicornuate or septate. Septate will be having narrow intercorneal angle. See the images, okay? Bicornuate uterus will be having wide angle. So that is how you differentiate between these two things, okay? So if you are having 2 cornua and two horns and 2 cervixes, then it is uterine didelphus. Don't make that mistake, okay? Don't make it wrong. So, a 36-year-old male working with a hammer and chisel had an accident with a foreign body. Which of this investigation will be detrimental? So, hammer and chisel injury, you should not do which investigation? Yeah, you should not subject the patient into a magnetic field. So, you should not do MRI. You should never do MRI when you are suspecting any metallic foreign bodies. X-ray is the first investigation. Ultrasound can be done. CT will be the best for finding out foreign bodies. Don't do MRI for foreign bodies. If it is a metallic foreign body, then you will end up in trouble. Patient will end up in trouble. Okay. So don't advise MRI for foreign bodies. You can take X-rays. Some of the foreign bodies will be radio opaque. Some of them will not be. Then you can do ultrasound. And if you want, you can go for CT. Now, which of the following part is obstructed in this image? Is it a small bowel obstruction because of perforation? Is it a large bowel obstruction because of ecoli? Is it a cecal valvulus or is it a sigmoid valvulus causing large bowel obstruction? Yeah, excellent. This is a sigmoid valvulus. You know this is the classical coffee bean. And you should know sigmoid valvulus will be a hostile. You will not be able to see any hostrations. Usually you will be able to see large bowel loops, but here you are not able to see any hostrations. Usually you will be able to see some hostrations in cecal valvulus. And see, that is how you differentiate between sigmoid valvulus and cecal valvulus. See, here you are able to see 1, 2 hostrations. This is cecal valvulus. So, hostra plus the sigmoid valvulus is a hostral. This is the most important point that helps you to differentiate between sigmoid valvulus and cecal valvulus. Okay. So, a patient, again NEET-PG 21 and FMG 21 question. A patient with abdominal distension came to you. So, what is the bowel loop that you are seeing? Whether it is a jejunal loop, duodenal loop, ileal loop, or transverse colon. Please tell me A, B, C, or D. Why jejunum? Everyone is telling jejunum. Why? What you are seeing? You are seeing complete mucosal folds. 1, 2, 3, 4, multiple complete mucosal folds. What are the complete mucosal folds called as? These are called as valvulae condimentis. These are called as the valvulae condimentis. These are the valvulae condimentis. So, how ileum will be seen when in barium will follow through an X-ray radiograph? What is the feature of ileum? Ileum will be featureless. Ileum will be featureless. There is no valvulae condimentis, nothing. In large bowel loops, any colon, what will be the feature? Large bowel loops usually has hostrations. Usually they will be having hostrations. Excellent. Hostra are the features of large bowel loop. So this is how you should remember things. Okay. So these are the anatomical questions that can come regarding radiology. Dilated jejunal loops, that is valvulae condimentis. Large bowel loops, it is hostrations. Yeah. What is the diagnosis? Baby with cyanosis. You are giving your favorite heart appearance. So I'm not wasting time. So this was actually an INSAT question. Air under the diaphragm in peptic ulcer disease. What would you do further for this patient? Whether you go for CCT, whether you go for IV fluids, whether you go for exploratory laparotomy or upper GI endoscopy. Yeah, first you have to start IV fluids. That is mandatory. And after that, you will do an exploratory laparotomy. If you are confident in the diagnosis of perforation, if you are seeing air under the diaphragm, then you can go for exploratory laparotomy because you are suspecting some kind of hollow viscous perforation. And what is the best X-ray view for pneumoperitoneum? Best X-ray view for pneumoperitoneum? Any idea? Best X-ray view for pneumoperitoneum? What is the best X-ray view for? Is it erect X-ray chest or erect X-ray abdomen? Yeah, it is chest erect X-ray chest. That is the concept. Okay, because when you are taking a chest X-ray, the rays will be more tangential to the diaphragm. So even a minimal amount of air will not be missed. Okay, but in abdominal X-ray, the rays will be centered in the umbilical region. It is far lower down. But in chest X-ray, it is centered and the rays will be tangential to the diaphragm, so that you will not miss even a single, even a minimal amount of air. In after a whole body CT was done, which will not the following will not be included. When you are taking a polytrauma protocol, you will be having to take CT brain. You know, brain is very important. Any brain injury can result in brain death. So limbs will not be included. Excellent. So you have to take CT whole spine. Then you have to take CT chest and CT abdomen. Preferably contrast, both of them with the contrast preferably. So this is what is called as polytrauma protocol. When there is a trivial trauma, when there is a serious or trivial, a very serious injury like a bike with a car accident, or like that patient is falling from 10 feet height or 12 feet height like that, then you have to take a polytrauma protocol and you have to rule out pathologies of spine, brain, chest and abdomen. So rule out all kinds of internal injuries. So match the following. Actually, these type of questions will be asked in INCT only, but just to tell the names of the sign, just 2 or 3 sides are remaining. I will quickly rush through. Rat tail sign is seen in which condition? So when you are hearing rat tail, you have to understand that this is carcinoma esophagus. String sign. String sign can be seen in either TB or pyloric stenosis. Okay. So this is here. The option is pyloric stenosis. Inverted umbrella sign is actually a sign of TB. And football sign is a sign of pneumoperitoneum. So just remember the signs. These signs may be asked. Last time Mount Fuji was asked, so it is better if you read the signs. Again, an INCT question. So this is actually a question which was asked in recent INCT only. Again, a patient is having difficulty in swallowing more for fluids. So if you are seeing history of swallowing difficulty more for fluids, what will be the diagnosis? What is the diagnosis in this case? Patient is swallowing difficulty more for fluids, and if you are seeing a classical appearance of esophagus with a smooth tapering. With a smooth tapering. So this is excellent. This is a case of achalasia. This is a case of achalasia cardia. You are seeing the classical bird peak sign. So what you have to do is you have to do upper GI endoscopy and the manometry. By manometry, in achalasia there will be absence of peristalsis. In achalasia there will be absence of peristalsis. So if you are finding out the peristalsis pathology, absence of primary peristalsis, you can do manometry. So it is not biopsy or pH monitoring. This can be done for GERD. This is done for esophageal cancer. So a 60-year-old patient, this was a question NEET 2020. So all these questions will be coming hand to hand. So you have to understand these bariums for this. So progressive dysphagia is there, more for solids. So history itself tells more for fluids. And if you see the narrowing, it is very irregular. So you are seeing an irregular rat tail like narrowing. Then what you have to do is you have to rule out carcinoma esophagus. You have to rule out carcinoma esophagus. Next what you will do, you have to do an upper GI endoscopy and then biopsy. Then for staging purpose, what you have to do is first you have to do endoscopy and biopsy, and for staging you have to go for HCT. And if you want to do TNM staging to know whether mucosa is involved, submucosa is involved, muscularis is involved, endoscopic ultrasound will help you in CA esophagus. Endoscopic ultrasound will help you in cases of carcinoma esophagus. Okay, that is the concept. This is how you will evaluate carcinoma esophagus. Esophagus is a topic that comes in medicine, pathology, radiology, surgery, ENT. So around 5 subjects has esophagus. So that is why that makes it very, very important. Another important spot regarding esophagus, we always discuss this in our class. When there is a patient with neck swelling, regurgitation of yesterday's food, some swelling here, when you push the swelling, there is regurgitation. What will be the answer? Yeah, this is Senger's diverticulum. So how will you differentiate between, Senger's? We will go for that. What is esophageal web? In esophageal web is usually you will see a shelf-like defect in anterior esophagus. Structure, you know, it will be narrowing. What is dysphagia lusoria? Again, INCT. They show, that is what I said. In INCT, they showed you one image causing dysphagia. Sorry, with the dysphagia lusoria because of aberrant right subclavian artery. So when there is an aberrant right subclavian artery, going behind the esophagus like this and compressing. Whether it is seen in X-ray, CT or MRI, barium, wherever it is, whenever there is a vessel passing behind the esophagus, you have to rule out aberrant right subclavian artery. That is the concept. Okay. This time they gave a CT angiogram image. Actually, it is not that easy to find out, but how to understand when aberrant right subclavian artery compresses esophagus, it can cause esophageal usuria. And coming to Senger's diverticulum and Killian Jamieson, it is very important. If they give you an X-ray lateral view, it is always Senger's, because Senger's is always posterior. This is usually left lateral. So it can be seen only in AP view. So if they are giving you an AP view, that is Killian Jamieson. So by seeing the view, you should know what is this. Okay. If they are showing a AP view with the left lateral diverticulum, then it is Killian Jamieson. Senger's diverticulum usually occurs from Killian dehiscens, which is actually a defect in thyropharyngeus and cricopharyngeus muscle in inferior constrictor. And this is occurring below the cricopharyngeus. So this is the differences. Just you should remember how to differentiate between Senger's and Killian Jamieson. Senger's will be seen in posteriorly. So it is seen in lateral view and it is seen in AP view. Just like remembering thumb sign and steeple sign. Finally, when they are showing you a calcified liver lesion, whenever they are showing you a calcified liver lesion like this, whenever they are showing you a calcified liver lesion, what will be the answer? Whether it will be a liver abscess, focal nodular hyperplasia, hydatitis, hepatocellular carcinoma. You know, if you want to make the diagnosis of FNH, HCC, liver abscess, you need contrast. But hydatitis, when it is calcified, see, you are able to see the membranes also. That is called as water lily. Calcified water lily actually. So this is hydrated cyst. Sometimes there will be honeycombing like multiple cystic lesions in hydrated. So these are the manifestations of hydrated cyst. That is called as honeycombing sign, honeycomb sign. So if it is a liver abscess, you will be seeing two signs. One is in our workbook, if you go and see, you will be seeing double target sign. Cluster sign in pyogenic abscess. Okay, two signs will be, because it is abscess, it will be surrounded by edema. So that is what is called as double target sign. FNH, you know, it is a lesion with what? Central stellate scar. FNH is having stellate scar. It is a lesion with the central stellate scar. So sulfur colloid positive. Hydatitis we discussed. HCC, you know, we have to do triple phase CT or MRA, and you will get what? Early arterial enhancement, because it is supplied by hepatic artery and washout. HCC is usually supplied by hepatic artery. Rest of the liver is usually supplied by portal vein. Since it is supplied by hepatic artery, it will show enhancement in early arterial phase. So it will show early arterial enhancement and washout. That will be the arterial enhancement and washout. That is the concept in hepatocellular carcinoma. So this is another case. What is the diagnosis here? What is the essential criteria for the diagnosis of neurocystic cirrhosis? So if you want to make the diagnosis, you should see the NCC with the central scolex like this. So you should be able to see the central scolex like this, see, and you have to confirm it by taking biopsy. So you have to do biopsy, and you have to get an MRA image like this. So it is 1 and 3. That is the concept here. And finally, again, one question from NEET-PG 2023. A 30-year-old female with bitemporal hemorrhage after fever. What will be there? When there is both the temporal lobe involved, what will be the diagnosis? If both the bilateral temporal lobes are involved, what will be the diagnosis? That is the question. Yeah, it is herpes simplex infection. Imagine if in question they involve bilateral thalamic involved. If they are telling you bilateral thalami is involved, what will be the diagnosis? Excellent. It can be Japanese encephalitis. So if it is bilateral thalami, it is Japanese encephalitis. Bilateral temporal lobe, that is herpes simplex. This is a NEET 2023 question. So a 30-year-old female delivered and CT showed a periventricular calcification. So when you are hearing periventricular calcification, what will be the answer? It should be cytomegalovirus infection. Okay, it is not toxoplasma, not herpes simplex, it is not parvo, it is cytomegalovirus infection. So that is periventricular calcification. Just remember CMV, ventricularly for weak. In toxoplasmosis, there will be diffuse scattering of calcification, multiple calcification, usually in basal ganglia. So that basal ganglia, diffuse pattern of calcification with the basal ganglia predilection is actually seen in toxoplasmosis. And imagine in adults, in toxoplasmosis, you will get a sign called as target sign. And it is usually seen in HIV patients when CD4 count is less than 200. It is usually seen in HIV patients when CD4 count is less than 200. So these are the questions that can be asked from toxoplasmosis as well as cytomegalovirus. Yeah, that's all. So I have covered almost all the questions which has been asked in previous INA-CT as well as our NEET-PG till 2023. Okay, so I tried to cover almost all the things. You have to make sure you are giving importance to all 19 subjects, not only the important subjects. You want to please try to go through all important points of all 19 subjects. Please don't stick on with one note like VSV alone or our workbook. Try to combine both VSV and workbook, because you know the competition is very tight. So you don't have any chance to make mistakes from the questions that are directly coming from the workbooks, okay, of any of these subjects. So please use the time wisely. Believe in yourself. Okay, first thing. Okay, please don't think that I had a bad experience in INA-CT, I will not get a good seat. Don't think like that. Be confident. Give your 100% in your exams. Okay, get the seat of your choice. Work hard. Okay, success will come. You have to believe yourself. You have to make use of the time. You have to work hard. Okay, any doubt, please let me know. I will stay for 2 to 3 minutes more, or else you please go revise the things, okay, and study well. All the best for exam. Please get the seat of your choice. Thank you so much.